call this meeting to order. Welcome to meeting number 26 of the House of Commons Standing Committee on Health. Today we are meeting for 2 hours with witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. Today's meeting has the themes of long COVID and COVID therapeutics. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021. Per the directive of the Board of Internal Economy of March 10, 2022, all those attending the meeting in person must wear a mask except for members who are at their place during the proceedings. Just a couple of comments for the benefit of witnesses. You have on your screen interpretation. You have the choice at the bottom of your screen of either Floor, English, or French. When you're not speaking, please ensure that your mic is muted. Please don't take screenshots or pictures of your screen. All of the proceedings will be made available on the House of Commons website. We are now ready to proceed with opening remarks. I understand that one of our witnesses is not yet with us, but is working through some technical difficulties and will join shortly, and that is Dr. Eric Aerts, a professor of the Department of Microbiology and Immunology at the University of Western Ontario. We have back with us today Dr. Emilia Liana Falcone, the Director, Post-COVID-19 Research Clinic, Montreal Clinical Research Institute, and attending physician, infectious diseases, Centre d'Hospitalier de l'Université de Montréal, and Dr. Kelly O'Brien, Associate Professor, Department of Physical Therapy, University of Toronto, and co-director of the Rehabilitation Science Research Network for COVID at the U of T. And representing the COVID Long Haulers Support Group Canada, Susie Goulding, the founder. Thank you all for being here today. The length of your opening statement should be 5 minutes or less. And we're going to start with Dr. Falcone. You have the floor. Welcome back.
Merci, Monsieur le Président.
Thank you, Mr. Chair. First, I would like to thank the members of the Standing Committee on Health for the opportunity to speak to you today and to share my thoughts. My name is Emilia Liana Falcone. I am an infectious disease physician at the CHUM of Montreal. I'm a director of the Microbiome and Mucosal Defenses Research Unit and the director of the Post-COVID-19 Research Clinic. We collaborate with colleagues from other institutions as well in order to ensure proper health care for them. COVID-19 has tested our resilience. More than 3.9 million Canadians have had COVID, and 10 to 30% are estimated to have long-term after effects. This could mean that more than 1 million Canadians could have long-term COVID, which means that they could be sick for years or months, which means that they are unable to return to work. The socioeconomic impact, of course, is significant. It is with this context that I would like to share with you the challenges and major issues that we're currently facing. The first challenge is diagnosing long COVID. It is quite complex. It is a heterogeneous disease with many associated symptoms, and symptoms like fatigue and shortness of breath overlap with other diseases. Therefore, we need to identify biomarkers that would facilitate the diagnosis of long COVID. The second challenge is to better understand the causes of long COVID from a mechanical perspective. This would allow us to identify biomarkers that would help us to better diagnose or predict the evolution of long COVID, and also help us to identify new therapeutic targets. Thus, we need to study new variants and vaccination on long COVID. We know that individuals can be reinfected and have post-vaccination infections. In our experience, Even if an individual did not have COVID after a first infection, this does not mean that the person would not be at risk for long-term after effects after reinfection. We also need to better understand the role of antivirals, not only to treat acute COVID, but also to prevent or even long-term COVID, especially considering that there may be virus particles lurking in the tissues.
Us that we need to be agile in our ability to adapt to evolving clinical situations as new information emerges. An effective way to do this is through the systematic integration of a research infrastructure into clinical care pathways. As I have mentioned in my previous participation in a meeting of this committee, my 8-year experience at the National Institutes of Health in the United States led me to suspect early on in the pandemic that there would be long-term sequelae of COVID. This is why I created the IRCM Post-COVID Research Clinic, thanks to the support from our governments. My objective was to integrate our clinical evaluation with a research platform and biobank that would lead to a better understanding of long COVID in an effort to identify diagnostic biomarkers and develop novel therapeutic strategies. Our research clinic model could be extended to specialized centers across Canada. This model would be even more effective if it were integrated into a network that would use standardized protocols and have an established infrastructure for real-time data sharing and integration. With this coordinated and rapid approach, we would further distinguish ourselves as a country, not only in the context of long COVID, but also in the management of other complex and chronic diseases and in the preparedness for the next pandemics. Finalement, une telle infrastructure
Such an infrastructure that systematically integrates research with clinical evaluation would foster collaborations between government, industry, and academic entities at the national and international levels. I still have several more thoughts that I would like to share with you, and I will be happy to continue the conversation during the question and answer session. Thank you for your attention.
Merci, Dr. Falcone. Est-ce que j'ai bien prononcé votre nom de famille? Est-ce que c'est Falcone? Falcone?
Falcone.
Did I pronounce your name correctly? Is it Falcone or Falcone? Falcone.
Dr. Arts, the professor of the Department of Microbiology and Immunology at the University of Western Ontario. Thank you for being with us, Dr. Arts. You have the floor for the next 5 minutes. You're on mute there, Doctor. That's better.
They'll never get old. Thanks for having me here today. I'll just give myself a brief introduction. I'm a Canada Research Chair in Viral Pathogenesis and Control. I just moved back to Canada. Well, it seems like just moved back 8 years ago. And I was 20 years at Case Western Reserve University in Cleveland, Ohio prior to that. So I'm a virologist. I hold a number of patents and I have an expertise in viral pathogenesis, diagnostics, and drug and vaccine development. I also, during the pandemic, we opened a new facility, a level 3 facility. It's called Imaging of Pathogens for Knowledge Translation Center. It is a level 3 facility that was open just 2 months before the pandemic in January. So we had one of the most modern facilities that was open, and lesson to be learned, never be a virologist and open a new biosafety level 3 facility just before a pandemic if you want a real life. Maybe it's the same in government. So just to give you a background on that, so the Impact facility has been working with about 30 different companies during the pandemic, several multinational companies, and we do global testing for antivirals, interventions, therapeutics, materials, and vaccines. To date, about 30,000 retail outlets, government offices, schools, et cetera, house products to prevent transmission, for which we tested for as service contracts with companies. So we also provide wastewater analysis for about 1/5 of the Ontario population through MECP in Ontario. And then we have contracts with Health Canada, and we provide the detection and the frequency of the variants of concern across all ports of entry in Canada. So that's through a contract with Health Canada, and we report twice a week to the Public Health Agency of Canada and Public Health Ontario. So I just want to shift in the few last remaining minutes about the shifting in the pandemic. So one of the things we realized early on is that this will eventually end, but the consequences of this pandemic will become much more severe, as the last speaker indicated. So after the 1918 pandemic and a flu in the 1957 and 1964 pandemics of flu, within a few years of those pandemics, we saw a major rise in the increase in cognitive impairment and neurological decline and neurodegenerative diseases. There's just been a study out by Harvard and University of Pennsylvania that talked about people post-ventilation, and approximately 40% of those patients that survived the ventilation in COVID are now experiencing cognitive impairments. And in addition to this, the disease itself, the severity of the initial COVID disease, doesn't seem to be linked to the development of potential cognitive impairments in future, which then could be linked to these neurodegenerative diseases like ALS, Alzheimer's, or early onset dementia, and Parkinson's. So the one thing that's an interesting observation, though, is unlike those diseases which I just described, we don't know the triggers of those diseases and can't identify when they occur. So one benefit, if you will, which is an unfortunate benefit, is now we have over 3 million people in Canada where we've defined when they got COVID, and we can start working towards implementing potential therapeutics that are already available to us. The models that can be set up is through various animal testing models that are well defined with cognitive decline, and determine which therapeutics can prevent that in animal models post a COVID infection in those animal models, and then rapidly parlay that to off-label therapeutic trials of these immunomodulatory drugs, anti-inflammatory drugs, and even antivirals that we never could do before, because we don't know what the triggers are for those diseases that can manifest themselves sometimes 10, even 15 years in the future. But in all predictions, if we even have a low percentage of the population that goes down this, what we would call a long-term COVID role in neurodegenerative diseases, we are looking at a second wave of this epidemic that will inevitably be much more costly for the healthcare system. The one good point is that we have a level of expertise in Canada that's really not replicated anywhere in the world. And there's been good investments already in BrainScan and a number of different facilities and research institutes across Canada and Western in particular. We have the leading experts in cognitive impairment that were recruited Canadians originally back to Canada from Cambridge just a few years ago, and they've set up the testing platforms, and then we bring in the expertise of therapeutics, antivirals to get engaged with that. But there's many places around Canada that can also contribute into this and be the leaders in the world in trying to combat this particularly devastating long-term consequence of neurodegenerative diseases, which we will likely see. And thank you.
Thank you very much, Dr. Arts. Next, Dr. Kelly O'Brien, Associate Professor, Department of Physical Therapy at the University of Toronto and the co-director, the Rehabilitation Science Research Network for COVID at U of T. Dr. O'Brien, welcome to the committee. You have the floor for the next 5 minutes.
Thank you very much for the invitation and the opportunity to speak at the meeting of the House of Commons Standing Committee on Health today. My name is Kelly O'Brien. I'm a physiotherapist and associate professor in the Department of Physical Therapy at the University of Toronto. I am a co-director of this newly established Rehabilitation Science Research Network for COVID with the Temerty Faculty of Medicine at the U of T. and co-director with Long COVID Physio, which is an international patient-led association of physiotherapists living with long COVID and their allies. As a chair, Canada Research Chair in Episodic Disability and Rehabilitation, my research has primarily been grounded within the foundational context of HIV. So, of which we and my colleagues are now applying these lessons learned from the context of HIV to now the context of long COVID. We know that a growing number of individuals are living with the persistent signs and symptoms following infection with COVID-19. And defined by the World Health Organization, post-COVID condition or long COVID occurs in individuals with a history of probable or confirmed SARS-CoV-2 infection, usually 3 months from the onset of COVID-19, with symptoms that last for at least 2 months. An estimated 144 million individuals are living with long COVID globally, and a recent systematic review involving 50 studies, of which 41 were included in a meta-analyses, concluded a pooled global prevalence of long COVID at 43%. And this spans non-hospitalized as well as hospitalized patients living with COVID. The long-term trajectory, as mentioned, of long COVID remains unknown. Therefore, conceptualizing the context of disability in long COVID is essential for better understanding the health-related challenges experienced by this community. And there is an opportunity to apply the lessons learned in other chronic and episodic conditions, such as HIV, to understand and conceptualize disability experienced among this community. So lesson 1 is to anticipate multidimensional disability and recognize its potentially episodic nature. Long COVID is a mass disabling event, and the episodic disability framework was derived from the perspectives of adults living with HIV to characterize the multidimensional and episodic nature of health-related challenges. This framework includes 6 dimensions of disability, all of which may apply to the context of long COVID. For example, physical health challenges such as fatigue, post-exertional symptom exacerbation or malaise, or shortness of breath seen among individuals living with long COVID. Cognitive health challenges, as was mentioned earlier, such as difficulty thinking or concentrating, resulting in mental and emotional health challenges in some cases, such as anxiety and depression. Difficulties carrying out day-to-day activities such as showering or meal preparation. And this all accumulates in having an impact on one's challenges to social inclusion, such as engaging in meaningful life roles, such as employment. This framework also acknowledges the disability dimensions that can be triggered by factors such as physical activity or exercise, prolonged cognitive activities such as engaging in intense or online meetings, or other health conditions. Currently, I have the opportunity to collaborate with a group of individuals in a CIHR-funded study to adapt this framework as a way to conceptualize the relapsing and remitting nature of some of the health-related challenges seen among people living with long COVID. And given the importance of the terminology in providing clarity and understanding among community and health providers, we recommend the use of the term episodic disability to characterize these experiences. Number 2, uncertainty and worrying about the future is a key feature of disability experienced among people living with long COVID. This is disability, the uncertainty of when an episode might arise, the severity and duration of that episode, and the impact it might have on one's health, financial, and emotional health considerations. And we're now dealing with new uncertainty of what occurs in the case of a reinfection among someone living with long COVID. There's diagnostic uncertainty where it can be difficult for an individual who did not have a positive PCR antigen test to access employment or income benefits or rehabilitation services. And there's financial uncertainty about if, when, and how individuals may be able to return to the workforce. Uncertainty is also in the part of health and rehabilitation providers in terms of how to safely approach and assess and treat individuals with long COVID. And lastly, uncertainty among health or employers and human resource professionals as to best how to accommodate and facilitate return to work. Number 3, There are similarities among those living with HIV and long COVID related to those facing health inequities, stigma, and discrimination. We know that long COVID disproportionately affects females, individuals in their prime career building years, and those working in social care, education, and with other existing activity limitations, conditions, or disability, which will have an impact and further compound the complexities of long COVID. Which leads me to number 4. The role and access to rehabilitation is critical to help prevent, address, and mitigate disability and health and enhance health outcomes for individuals living with long COVID. Rehabilitation, such as physiotherapy and occupational therapy, can have a role in being goal-oriented, person-centered, and focused on function and tailored to an individual's goals and abilities. Lesson 5 is the importance of ensuring a patient and community-engaged rehabilitation response. And in combination with this, having a greater and meaningful involvement of people living with long COVID who are people living with and affected by the pandemic, and to build on existing research and clinical networks in rehabilitation that can provide foundations for long COVID, taking a strength in numbers approach and partnering with other chronic and episodic conditions such as myalgic encephalomyelitis or chronic fatigue syndrome in helping to inform future rehabilitation approaches and policy. So in summary, a safe and effective and coordinated response to rehabilitation is critical in the context of long COVID. And while evidence continues to emerge, rehabilitation professionals are positioned to help to address episodic disability, and opportunities exist to build on some of the successful disability and rehabilitation models from other chronic and episodic illnesses that may apply to the context of long COVID. Thank you very much for your attention.
Thank you, Dr. O'Brien. And next, we're pleased to welcome Susie Goulding, the founder of COVID Long Haulers Support Group Canada. Welcome to the committee, Ms. Goulding. You have the floor.
Thank you for this opportunity to address this committee. Long COVID needs to be acknowledged. It is a mass disabling event on a scale that has not been seen by most Canadians living today. All Canadians, public healthcare systems, policymakers need to be aware of the complex issues of long COVID, how it negatively affects the health and livelihood of Canadians, and the impacts it has on the workforce and the economy. Canadian long haulers urgently need funding for research, treatment, and lost income for many too disabled to work. Long COVID, as mentioned, is a debilitating episodic illness with symptoms like cognitive dysfunction, brain injury, crippling fatigue, and post-exertional symptom exasperation. From toes to testicles to the temporal lobes, nothing is spared. People are unable to stand, walk, or even sit up in bed due to post-POTS like symptoms and dysautonomia. They're bedbound, they are housebound, and they need mobility aids to move. Basic tasks like showering and getting dressed can cause heart rates to soar for hours. Few qualify for financial supports, savings are burned through quickly, and people are left in desperate situations. Healthcare coverage is desperately needed among long haulers, as many Canadians don't qualify for long-term disability insurance. Because of a lack of PCR testing, not having a positive result, people are denied and refused claims. EI benefits only cover 15 weeks of illness when long COVID is a minimum of 12 weeks to just get a diagnosis. The impact of financial hardship is extreme. Small businesses close, jobs are lost, relationships end, and the stress of these great losses makes symptoms worse. It's a vicious cycle. Some long haulers face eviction, homelessness, and talk of suicide. We're fired from our jobs for underperforming or not showing up when we are sick. We want to get better. We want to contribute. We want to earn a living. We want to be healthy. And we are trying, but we need your help. Too many long haulers are not believed. We are gaslit by doctors. We're told it's all in our heads. We're treated like pariahs. We need long COVID to be defined as a disability so we can access existing programs and supports. We need emergency benefits that are similar to the CERB, regardless if you were employed or in between work or self-employed or an unpaid caregiver at the time of sickness. Resting and pacing is suggested, but it's not achievable for people who have to pay bills or children who have children to look after. Recovery should not be a lottery for only those who can afford not to work and have significant outside supports. While Canada has treatment clinics, there aren't enough to deal with the sheer volume of long haulers, and most of these are capped off at max capacities. Knowledge of what does and what doesn't work is beginning to develop. It needs to be disseminated. Federal, provincial, territorial, and governments need to coordinate efforts. A national strategy needs to be committed to by all. Information and knowledge needs to be robust, distributed so all healthcare and allied professionals know how to recognize long COVID and treat symptoms by avoiding doing harm. COVID Long Hauler Support Group Canada has participated in countless studies, nationally, internationally, provincially. We've partnered with Vinex, Viral Neuros Exploration, Brain Health Charities, over 2,000 people with surveys. We are patient partners, we are advisors, we are in many research projects in this country, and we suggest that this be expedited. Robust funding for coordinated longitudinal research needs to be strategized, prioritized, and funded. The $20 million that was given is allocated towards research for long COVID is a great start, but so much more is needed. There needs to be vast funding. There's a burning need for research and treatment for kids with long COVID. They are underrepresented and the least understood. Parents and pediatricians need to be educated to recognize and treat symptoms. Kids are missing out on their childhood, peer relationships in school through absenteeism. They need special accommodations in school to help them succeed. These needs are urgent and need to be prioritized. Excellent work is being done. What is lacking is coordination of efforts and funding to match the scale of the problem. Internationally, Canada lags behind its G8 neighbors in commitments to long COVID solutions. But with proportionate funding and national strategy, we could be a global leader. The vaccine rollout has proven it is realistic to create partnerships that will address the needs of all long haulers. On behalf of our nearly 17,000 members, the 400,000 to 1.15 million people suffering from long COVID today, I thank you in the committee and I beseech you to take swift action on these matters. People do not pretend to be sick. With long COVID, long haulers are pretending to be well. Thank you.
Thank you, Ms. Goulding. We're now going to begin with rounds of questions, starting with the Conservatives. Dr. Ellis, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all of the witnesses who came today. Certainly a very interesting topic and timely, of course, which, as we move forward, we'll have to spend more and more time on this topic. I'd be interested, simply as a comment to Dr. Arts and Dr. Falcone, if you may provide any papers you've authored or co-authored here to the committee. I think that would be fascinating for some background reading. That being said, Dr. Arts, through the chair, you spoke briefly about the interest that you have with respect to COVID in the future at some point becoming a nidus for neurodegenerative disorders. And I'm wondering if you might enlighten us a bit more on that. And also, you talked a bit about perhaps brain scan changes and some of the agents maybe that may be useful to fight this potential onslaught of neurodegenerative disorders. So, if you could provide some context with respect to that, that'd be great.
Certainly, thanks. Thanks for the question. And yes, so of course, we all hope that this surge is not coming in. Anywhere between 5 and 10 years, we suspect, with early diagnosis of cognitive impairments already been observed, there's been a number of clinical studies that have looked at neurological consequences, particularly through neuroimaging, and some of these things can be diagnosed early. I think one of the interesting concepts that's emerged, though, in this process is normally there's always been a thought to be there's a linkage between infectious diseases and in many cases viruses. So one of the witnesses described HIV. HIV is a very unfortunate, it leads to a lot of neurodegenerative diseases, and we saw that very early on in the absence of treatment. And when we received, when treatments were available, these different complications that led to many neurodegenerative diseases and cognitive impairments actually reduced dramatically. And now, actually, in HIV, this is a very uncommon secondary infection and secondary disease. So one of the points with this is to try to identify therapeutics early on with things that we never had in the early days, for example, with HIV infections. And there's been an explosion in pharma with anti-inflammatories and immunomodulatory drugs and even antivirals. So you can envision, even though the antivirals that exist today don't necessarily have a great impact in shortening the duration of disease, the COVID infection that is, it could be instrumental in reducing the inflammatory responses that are likely the triggers for long-term COVID in general, but in particular in reducing early onset dementia and the diseases I described earlier. So we have the opportunity now to screen for these drugs using very sophisticated animal models that had never been available before, specifically in cognitive early onset, early diagnosis of cognitive decline and impairment. And as a consequence, we can start looking at the drugs that are already available to us and try to identify ones that will be effective. And those particular drugs that are most often Health Canada approved then could be parlayed into clinical trials pretty rapidly, because we are all developing these cohorts of long-term COVID and try to stave off what we see as the coming pandemic. So that's the way we kind of envision this approach. And as we screen for these current drugs that we have available to us, we try to identify the pathways leading there and develop much more targeted therapies that can be applied later with maybe reduced side effects, for example. So that's the way the academic community is envisioning it that study this area. And fortunately, we do have the tools and investments were made early on, but of course, this is a pretty long-term, heavy financial commitment. But it is one that could save us billions in the future and preserve our healthcare system. So I hope that answers the question.
Thank you, Dr. Artz. And I think maybe I have a couple minutes left. 1 minute, great. Through you, Chair, Dr. Falcone, you talked about some biomarkers, which I assume will kind of fold nicely into Dr. Art's work as well. Are these new biomarkers, or are they things like CRP and D-dimer, ESR, et cetera, that we already know about?
Thank you for that question. So one of the things that we were able to do is actually we systematically evaluated those biomarkers that you mentioned, because they're clinically available and widely used. In our experience, those are not the biomarkers that will aid in diagnosis, so we have to dig a little deeper. So some of the candidates that we are investigating go in the realm of things like autoantibodies, but in broad scale levels, and we're doing this through collaborations at the international level. There's also elements that have to do more proteomic markers, as well as immunological signatures. One of the specialties of my research group is actually to look at the microbiota and some of the metabolites. So the microbiota is the community of bacteria that live in any given area of the body, but we're particularly interested in the community that lives in the gut. And this does have a profound effect on interactions with the immune system and inflammation and immune dysregulation. So the microbiota is another example of a potential biomarker or elements of what the microbiota produces, such as its metabolites, for instance.
Thank you, Dr. Falcone and Dr. Ellis. Next, we're going to go to Mr. Joe Harry, please, for 6 minutes.
Thank you, Mr. Chair. Thank you to all our witnesses for coming today, and welcome back, Dr. Falcone. I'm going to start with you. In your opening remarks, you talked about agility, and you said that's one way to be able to deal with the aftermath of COVID. And you specifically talk about integration of research into what I believe I wrote down as clinical evaluation. And you also said if you have some time during the question, you have a number of other ideas that you'd like to share. So here's a platform for you to share your other points of view that you wanted to share with us.
Mm-hmm. Thank you very much for that question. So what I would like to share is sort of more concrete examples of how we can implement a setting where we integrate research platforms with clinical care. So for me, based on my experience at the National Institutes of Health, this was something that we just lived on a day-to-day basis. So it means that, concretely speaking, is that when a patient is admitted into clinical care, be it in an outpatient or an inpatient setting, that they be from the get-go consented onto research protocols. Now, these research protocols can be as granular and comprehensive and detailed or not, depending on the infrastructure and the resources available, but already having the ability to even collect clinical information with informed consent in a way that can be harmonized amongst different research groups locally and also nationally and potentially, even beyond, would already be one major step that would, for instance, increase our agility, because we would be able to collect and analyze these data in real time and have these informations inform our next steps, insofar as even something has the pertinence of certain clinical evaluations. How comprehensive do they need to be? We know that patients with long COVID, when they're not in a long COVID referral center where there is an awareness and acknowledgement of what the disease is, they are often bounced around amongst different specialists, leading to lots and lots of tests. Some are helpful, some are not. This is a huge waste in resource and in time and in energy for the patient. As we've heard from Ms. Golding about how small efforts can translate into big setbacks, functional setbacks for these individuals. So that's for one example. And then if we add another layer to that, where we collect even just a little bit of biospecimens, even if it was one tube of blood, there's a lot we can do with that, from a genomic evaluation, gene expression data, looking for biomarkers. A lot of them are easily found in a substrate of a blood sample, like the plasma or the serum. And all of this, and it's in small amounts with our current technology, all of this can be harnessed into improved clinical care and possibly more rapid identification of new therapeutic targets. We speak a lot, at least in Quebec and I'm sure in other areas as well, of analyzing big data and artificial intelligence and harness this kind of ability for us to learn more. Well, one thing that you need for these kind of scenarios is a lot of data, right? You need that to have access to that data in a way that is that the patient is aware of, that has consented to this. And so the only way to do that is to start collecting it from the beginning.
So for collection of that data, I think one can talk about regulation, but I think the patient consent and educating the patient at the outset is a key determinant. Wouldn't you say so?
Absolutely. But the more individuals are informed and the more they understand the implications, and of course, with all the right security measures and protection, obviously, of confidentiality, which is absolutely key, in my experience, we find that, and I think, even in other experience, and perhaps Ms. Goulding can speak to this, when we involve patient partners, there's a really keen interest in participating in the improvement of care. I mean, we find often that, patients are really enthusiastic and want to see change.
Got about a minute. I want to go to Dr. Art. Dr. Art, I'm not a medical doctor, or I don't have any medical background. I come from a management consulting background, and I always ask some fundamental questions. Does being vaccinated or not vaccinated have an impact on an individual ability or the fact that someone can develop a long COVID or not, or even when they develop a long COVID, whether it could be treated with different therapeutics?
Yeah, that's another good question. And I also am not a medical doctor, but I can give you my opinions based on my knowledge. So that's one of the things we need to ascertain and understand more clearly is if you get infected with different variants, because specifically with Omicron, it's quite a different type of viral infection. We don't know how that's going to impact yet the development of sort of what we call short-term long COVID and potentially long-term non-COVID disease, long COVID disease. So that's one aspect we have to understand. The other thing is, how does vaccination mitigate the development of long COVID when you do get infected? So we know the severity of disease if you've been vaccinated is reduced when you get infected, and now more so with Omicron, which tends to be a wimpier virus in terms of pathogenesis. But we still don't understand fully as to how that's going to impact specific cues that establish what would be cardiovascular complications, and which further link to cognitive impairments and any other neurological diseases, and which a lot of people are suffering from. So those studies still need to happen, but I don't think we should wait in our development of therapeutics to try to define all the characteristics. We should be embarking on therapeutic development and testing as soon as possible, because it's a longer manifestation of disease, we need to be looking at ways to cut it off at the knees, if you will. So that's my interpretation. And yes, I agree with Dr. Falcone that cohort development at the same time as you're dealing with drug testing, specifically those drugs that are already available, is going to be essential, because you need to be able to parlay that immediately into like a phase 2 off-label clinical trial. And then you can see pretty rapid use of that in the clinic to potentially negate these long-term effects. But all what we're talking about has to be somewhat of a coordinated response. And a lot of countries in the world are grappling as to how to deal with it. I think I'm surprised as to how much progress we've already made in that development. And I think we stand a good chance of leading the world in that regard.
Thank you, Dr. Arts and Mr. Johari. Suite, c'est le tour.
Next, Mr. Garon. It's fantastic to see you again. I hope you're doing well. The floor is yours for the next 6 minutes. My COVID symptoms did not last all that long, I presume because of my vaccination. Of course, I encourage Quebecers and Canadians to get vaccinated. And you already know that, of course, Mr. Chair. I'm going to do something that I don't do often. I'm going to go off the last question. I'm interested in the link between vaccination and the probability, first, of either having long COVID, and two, the importance of the symptoms. I think I may have detected, Dr. Falcone, you might have something to add here to Dr. Art's thoughts. Indeed, it is something that really does interest us. First, it could give us a little bit of optimism, but it would also help us understand the pathology of long COVID. With regards to numbers, we did have some indications from the United Kingdom. Vaccination was purported to diminish the chance of having long COVID by 50%. That was quite optimistic. Another study from the United States suggested that it would be a little bit less than 50%, so 15% rather. Each study has its limitations. They use different data. That said, what we do see is that vaccination can help. If we don't have COVID, then we have less chances of getting long COVID, of course. And if we don't have a pre-existing condition, where you could be hospitalized or have some symptoms that are related to that group specifically. But for the 90% of other patients that were not hospitalized when they had COVID and do have long COVID, we do see that there could be a decrease, but long COVID does not disappear. So we definitely have to have a new approach. We need treatment. Something else that is important, what would the impact of treatments used in the acute phase of COVID could we be using to diminish the risks of having long-term consequences? I'm thinking of Paxlovid, for example. Pharmacists in Quebec are sometimes allowed to prescribe it. Are we seeing any studies or results that demonstrate, for example, that using this medication more often could reduce the probability of having long COVID? Could it be one of the treatments for the acute phase? It could be, but we don't have the data. We have data with regards to diminishing having a serious case of COVID or death even, but for cases that are less serious but that are acute or with regards to that idea, it is a very interesting hypothesis that we should be investigating. The other question that we're asking ourselves is as follows. Can Paxlovid treat long COVID? We need to investigate that further. What we see right now is purely anecdotal, where there might be an improvement in symptoms, but we don't know how long that improvement lasts. Thank you, Dr. Falcone. Here's a question. Among the public, there is this idea that COVID, or long COVID rather, is not something that really exists. Do you think that you can maybe expand on how those ideas came to be? Well, I would say that Ms. Golding spoke to that. Apologies. There are some doctors that don't recognize or acknowledge that the illness exists. There are some people who have a certain doubt, and it is unfortunate. It damages how we take care of those patients. it also impacts them going back to work and their sick leave. It does impact their functionality, for example. There has been some evolution, but we do need to educate with regards to long COVID. Do you think it's because maybe the symptoms are not recognized properly? Maybe they're not very different from COVID itself? Is it because there is a lack of clinical criteria? How do you explain this? What do you think should be done? Should we be communicating better with doctors because it's evolving too quickly? Well, there are multiple factors here. First of all, there are many symptoms that are associated to long COVID. Some are common to other illnesses, as we already mentioned. We have to evaluate the patient holistically before and after their infection. We have to understand how this person really evolved in order to arrive to a diagnosis. It is challenging. There must be at least one symptom that has been persisting for at least to 1 month. They can evolve over time. They can come back after having disappeared, and all this impacts the definition. So it's quite challenging. And for doctors who are not familiar with, for example, tools that can evaluate certain symptoms that are less apparent, or POTS, for example, requires certain expertise. If the doctor doesn't necessarily have that expertise, well, we need to find means to ensure that they have the right tools or give them proper resources so that they can refer their patients so the patients can be holistically evaluated. Thank you very much.
Please, for 6 minutes.
Thank you, Mr. Chair, and thank you, the witnesses, for being here. Dr. Falcone, just so I'm clear, is there a standard clinical case definition of long COVID?
Yes, there is the one that was established by the WHO.
Has the Canadian medical establishment adopted that definition?
Well, we usually point to it. There's also one that was established by the CDC as well. So we tend to observe, both definitions. It just becomes a question of, do you use the cutoff of 4 weeks or 12 weeks? And this is really something of debate, because you do see a lot of improvement between 4 and 12 weeks for a subset of patients. You got this almost 40 to 50% that have this improvement, but then you're left with this other significant chunk that persists for a long time. And as you go beyond that 12-week cutoff, we start to see that the curve plateaus. And then you start to see what really looks like the phenomena that is a chronic illness.
What I'm trying to get a handle on is, long COVID seems like it's real. I'm just wondering, is it recognized by the medical profession in Canada to the degree that it needs to be?
It is recognized, but like we've mentioned, probably not to the degree that it needs to be, in the sense that, I think there needs to be more education. When we are, in certain circles, we do see that there is a lot of, there are doctors who are familiar with it, but I still hear stories, including from my own patients, where they're not, it's not being considered, or there's uncertainty. It's just a certain, it's not it's not as well known as other disease. It's still really new.
Dr.
O'Brien,
Falcone, we're having a little trouble with your sound quality. Can you move your mic either up or down about 1/4 of an inch? Just say a few words.
Is that better?
That's better?
I hear echo now. Is that better?
Okay, thank you. Go ahead, Mr. Davies.
Thank you. Dr. O'Brien, just as close as you can, what percentage of Canadians have had COVID-19, and what percentage of those have experienced long COVID?
Oh, thanks very much for the question. I do not know off the top of my head how many Canadians have had COVID, but in terms of some of the data, in terms of the prevalence rate, it's been estimated anywhere from 10% to 30% of individuals that can develop long COVID. And a lot of it is variable depending on how the literature define long COVID. As Dr. Falcone mentioned, there was a rapid review done in Ontario looking at a high-level systematic review evidence of the prevalence of long COVID, and it included a number of systematic reviews with over 10,000 patients and concluded a pooled estimated prevalence of 51 to 80% of long COVID. Now, the definition they used for that rapid review was anyone who experienced a symptom at 4 weeks. So as was mentioned earlier, with the World Health Organization's definition, defines long COVID as symptoms that persist after 12 weeks, and that they do so 2 months in duration. So I think that's why we're seeing so much actually variability in terms of the prevalence. Is there, it really hasn't been a universally adopted definition of long COVID.
Ms. Golding, to you. It's funny, in preparation for this meeting, I mean, I've been on social media, and there's an unbelievable counter reaction, it seems, to people who are suffering from long COVID. So I'm wondering if you could outline for us some of the impacts that stigma, or I think you used the term gaslighting, is having on long COVID patients across Canada.
It is critical, and it is causing damage to being able to recover. If you don't have a doctor who can diagnose you or believes that you have these issues, they're not going to be giving you support and seeing you on to the specialist that you need. What I wanted to mention was that in the beginning of the pandemic, and the focus has always been on deaths and recoveries, and long COVID has always missed the mark in being part of the conversation. So this goes way back, and this is why there's little information. And as Falcone was saying, doctors at this point today are still under the assumption that long COVID doesn't exist. In some smaller areas, you have to excuse me, I have issues with my brain after having COVID, with long COVID, and I struggle to find words sometimes. So the word slips me there. But the point that I'm trying to make is that it is very difficult without the support of the doctor, without the doctor having knowledge. And this is one of the huge issues that patients are having, finding a doctor that has information, has basic knowledge on how to recognize the symptoms, because we don't have a positive test result to go on. So it needs to be a clinical diagnosis. But if the doctor doesn't have an understanding of what they're looking for, or how to diagnose properly, or the channels of treatment and where to send us, then we don't have a hope at recovering or being heard. And this is where depression and anxiety start to fester, and people are left without, supports of, not even being able to cook or clean, or being just disabled without functionality in society. So it's a really vicious circle, like I mentioned. And the doctors, I think one of the most important things is doctors really need to have an understanding. This information flow needs to start from the federal level, and it needs to be broadly disseminated so that they can recognize.
Thank you, Ms. Goulding. Mr. Davies, next back to Dr. Ellis, please, for 5 minutes.
Mr. Chair, I appreciate that. One of the things for medicine that we need to learn from is to have a patient-centered focus. And Ms. Goulding, thank you for being here. One of the concerns I have, we've just finished a health human resource study, and one of the concerns I have is not only finding a physician or a health professional who believes your diagnosis, but actually accessing a health professional at all. Is that something that you've heard from your members has been a difficulty?
The word I was looking for was rural communities. Yes, absolutely, that's a problem. People in the Northwest Territories, in the Yukon, in isolated communities, Indigenous communities, people out east, in the Maritimes, people provinces and places that haven't had like a large case count of COVID then don't go on to have an understanding of what long COVID is in the beginning because they just didn't have the case count. So they just didn't have the experience of seeing it in their communities. But now this is changing with the broad infection of Omicron, and people are getting infected everywhere. Children are getting infected. So yes, it is a disability, or to be in not an urban community, to have access to care, to have access to doctors who have knowledge, and to have access to actual rehab centers, because the centers you see are provided to communities with high case counts in urban centers.
Thank you very much. That makes perfect sense. And Mr. Chair, through you once again to you, Ms. Golding. Just to be clear, oftentimes in committee and in government, we work really much better with just a few simple things. If you could kind of give us 3 top things of what you would like to hear from a patient's perspective of what you think we could do. And I understand that perhaps you don't understand always how the government works. That's no problem. But if you could just give us 3 things, you say, hey, here's what I think the government should do, A, B, and C. Could you tell us what they would be?
Thank you so much for your understanding. What I think would be really meaningful to long haulers would be the acknowledgement and messaging in public health and across the nation that long COVID is an issue, that it does exist, and that people need to take the necessary precautions not to catch COVID so that they, in turn, don't catch long COVID, because it's nothing that you want to mess with, and you certainly don't want to have your life thrown to the wind because of this virus. So that would be number 1, messaging. Number 2 is definitely funding research. This is really a top priority, that a plan of execution needs to be made, coordinating all the provinces and territories, and really putting a focus on this, prioritizing it, and massive funding so that, the studies that are being done now with the $20 million that are allocated, can end up being piecemeal studies where we need large longitudinal studies that will really look at the underlying mechanisms of what long COVID is. And so clinical studies set up, and so that's very important. And then number 3 would be the treatment of long haulers. It needs to be accessible to all. This is an issue of challenging issue with the healthcare communities, running on empty right now, and to bring long haulers in on top of that, it's a crisis, and so it needs to be expedited and really looked at through a magnifying glass at how critical this is. And, there's studies out of Australia that are already noticing the effects on their economy, and that the work, that their workforce is being affected, and that women are, disproportionately suffering from this disease and are falling out of the workforce. Our caretakers, families, caregiver roles, it's just everything is being affected. So those would be my 3 points.
Thank you, Ms. Goulding and Dr. Ellis. Next, we're going to go to Dr. Hanley, please, for 5 minutes.
Thank you. Thank you to all the witnesses for this testimony, and particularly Ms. Goulding, having both your personal experience and your advocacy, despite your own challenges. It's fascinating and so important to hear your testimony. But I'm going to give you a break. I'm interested in the when Dr. Arts, you talked about the advantage that we have, so many people infected as a kind of potential for cohorts. But I'm going to pivot to Dr. Falcone for now and just ask, is it also a disadvantage that COVID is now becoming so common? I think I know more people that have had COVID than have not. Maybe I'm mixing in the wrong crowds. Personally, I've been spared so far, but is long COVID clinically distinct enough that we will still be able to recognize it, given that the increasing prevalence of people that have had COVID? Or will we really be dependent on that search for biomarkers?
So I think we will certainly be able to distinguish the patients who have long COVID from the patients who had COVID but did not develop long-term symptoms. Although that becomes even more concrete when you look at the evolution over time, because not everyone will go on to develop long COVID exactly at the same time point, or the symptoms might not be picked up or diagnosed, at exactly the time point that one would want. Of course, with the fact that there's more and more cases of COVID, what you lose is the cohort of patients who never got COVID. So your negative controls, so to speak, which help you understand a little bit, sort of tease out some of the background of the infection itself and how that distinguishes it from long COVID. That being said, this all the more highlights the need for, yes, larger cohorts that are, followed longitudinally, and yes, diagnostic biomarkers. But the diagnostic biomarkers, they'll have another purpose as well, right? They may help tease out the diagnosis of long COVID from other illnesses that have some similarities or some overlap. They will also be a support for the clinicians who might not be able to fully grasp at all the symptoms and all the nuances of this complex entity, and so it's in that sense too that we would like that people deal well with an objective finding. So if we could find that, it would be helpful.
Yes, and it was more in that latter category of people presenting with non-specific symptoms who may have had COVID. How to distinguish the long COVID from perhaps other syndromes that we have always had, as clinicians have had to tease out what's going on, and especially when we're talking about therapeutics. But I want to just use my remaining time to turn to Dr. Artz, and it's really interesting to hear your observation about the post-pandemic effects that when you see a kind of a peak, as it were, of neurodegenerative diseases in the years following. Surely we then must be seeing that with seasonal influenza and looking for connections. I know that's perhaps a connection that's being sought to be better defined. So I'm wondering if you could comment on that relationship between what is the common pathophysiology potentially between influenza and neurodegenerative, and COVID and neurodegenerative? Is it the inflammatory response? Is it something, given that they're very different viruses, is there something else, or is that still what we're looking for?
So it's always confusing. We don't have a. So when we talk about seasonal flu, we kind of lump them together because it happens so frequently. Like if you go back into a person's lifetime and they've developed early onset dementia or Parkinson's, they may have had several episodes of flu, and so you don't definitively know. The difference with the 1918 or 57 or 64, those are more large antigenic shifts. And so our immune systems don't recognize it as well. There's a greater chance that we have a higher level of inflammatory responses with the infection. And that respiratory infection with inflammatory responses often trigger neuroinflammation responses that can lead to this type of progression. And so what I was referring to is, we've been studying, and I'm new to the neurosciences field to a certain extent. I've been gotten a rude lesson, if you will. But, we've been studying neurodegenerative diseases for 30 years. And in that period of time, we've never developed a treatment that dealt with early onset aspects of those diseases. And, now we have something that occurs a little bit earlier, not approved in this country. But when you look at it, our drug development pipeline for Alzheimer's and Parkinson's is very, very poor as compared to other diseases. And that's because we can't define when the triggers have occurred. So knowing what's happened in the past and knowing what potentially happens now, and even the signs and symptoms that we're discussing today in sort of the near long-term COVID, already causing pretty significant cognitive impairments, which are possibly also associated with, advancement of even cardiovascular diseases, clots, et cetera. What we're looking at is the ability to define the disease and the triggers and then make some inroads on treatment, especially that now, again, and this is hard to share, but we have these amazing animal models where we can induce the same disease and then apply touchscreen cognitive tests in those animals the same way we do it in humans with the same type of test, and then look at the treatments that might be available already, looking at how they may impact mouse studies, for example, and then apply them to humans, especially with approved drugs. These are types of things we can never study unless we know the trigger and, of course, establish what those biomarkers are. But, one of the things I fear is a lot of biomarkers are going to be very hard to assess, as Dr. Falcone indicated. And the other thing that Ms. Goulding indicated as well is the availability of those diagnostic and disease monitoring tools. And I think we'll have to be relying on neuroimaging quite a bit in diagnosis, disease progression, and the effects of treatment.
Thank you, Dr. Hertz and Dr. Hanley.
Yeah.
Next, c'est Monsieur Garon.
Next, Mr. Garon, 2.5 minutes. Thank you. I'd like to ask a question to Ms. Goulding. I found your testimony very touching and very moving. For a few years, the Bloc Québécois has been working hard so that for severe illnesses, healthcare could be expanded to cover longer times, up to 55 weeks. There is a bill in the House of Commons that is being currently studied that would extend EI to include this. Do you think that this measure could eventually help people who have the most severe version of long COVID in order to help them care for themselves in a more dignified way?
Thank you for asking me this question, because I really dropped the ball on the other question that was asked to me. Benefits are needed yesterday. People are suffering. They're losing their homes. They can't provide medicines for themselves. They can't eat properly. They're eating Kraft dinner and it's catastrophic. So benefits. Yes, definitely 55 weeks would really help. It almost seems as if the people who are able to rest in the acute stages of catching COVID may be the ones that recover better. So pacing is recovery. The more that you can rest, the more that you can pace yourself. And by pacing, I mean doing only what your body tells you that you can. It's like having a day, looking at your day with a battery that's half full and being able to do only what that allots you to do with only half the energy that you would normally have. So that's how you have to go about your day and get everything done. So you have to prioritize. So definitely 55 weeks would be a great help, because if we can give aid to people who are trying to recover, they don't have to worry. They can take the time that they need. They don't have the stressors that are making things worse. They can relax. They can take the time that they need. And maybe this could be the difference. It could be the difference. So thank you so much for asking this question. And yes, absolutely.
Merci, Monsieur Garon.
Thank you, Mr. Garon.
Please, for 2.5 minutes.
Dr. O'Brien, my information is that women appear to be disproportionately affected by long COVID by as much as a 4-to-1 ratio. Is that correct? And if it is, are there any theories about what might explain that disproportionate impact?
Thanks very much for the question. Yes, the prevalence of so females are a predicting factor. So sex is a predicting factor when it comes to experiencing long COVID. And the hypothesis there that there is some evidence to suggest what might be a predisposing factor, placing someone at a higher risk of establishing long COVID. And one of those is autoimmune conditions, and women have a higher rate of autoimmunity. So there is that linkage there. And I see Dr. Falcone nodding her head. And the other hypothesis is that women tend to be in employment situations that have placed them at higher risk. So personal care workers, education workers, other healthcare workers who didn't have the ability to take the time away, perhaps as Ms. Golding mentioned, to have purposeful rest and recover in the acute phase of COVID, and didn't have the opportunity for sick leaves or benefits, for example. So there's that hypothesis there as well.
Is there any linkage between the prevalence of long COVID and vaccination status?
So that's a very good question. And I think something that the evidence is still emerging. As Dr. Falcone mentioned, initially there was some promising evidence to suggest that vaccination does have a protective effect against long COVID, but most recently there was an article that came out in Nature at the end of May that suggested that vaccination was only partially protective against long COVID. So I think the evidence is still emerging there, and the time will tell as the evidence further emerges.
Thank you, Dr. O'Brien. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair. For those of you that follow along at home, one thing that you perhaps don't see that happens in part of the Health Committee is that we receive a large number of briefs from individuals from all across the country that share their perspective on a variety of different things we study. And I think it would be fair to say that this particular study that we have has received a very high amount of briefs. It seems like just about every day, or at least every Monday, we've got a pile full of briefs. And I want to let everyone know who is following at home, and especially those who have written in those briefs, at least my colleagues on the Conservatives, and I see some heads nodding. I believe just about everyone takes into consideration all of those written briefs that we've been receiving. And there was one that hit me today that we received that hit me probably a little bit more than others because it's so similar to so many of the emails that I've received into my constituency office. And it was one that talked about someone that was unable to fly due to ongoing travel restrictions. And as a result, she was going to miss a family funeral. And funerals are such emotionally charged moments in people's lives. And to me, it's just really sad that these travel restrictions are having such a huge impact on so many people's lives. And so as a result of some of these briefs, I would like to move a motion that the committee is of the opinion that travel mandates in relation to COVID-19 be lifted immediately, and that the chair report this motion to the House at the next available opportunity. En français, que le comité soit...
That the committee is of the opinion that travel restrictions related to COVID-19 be immediately lifted and that the chair present this motion to the House at the next convenience.
The motion is there has been no notice provided, so we can take this as notice of motion and bring it forward at a later date.
Mr. Chair, I'm of the understanding that as long as a motion is in relation to what we are currently studying, it is within order.
All right, I take your point. The motion's in order. And I guess we are now obligated to debate the motion unless you want to defer it so that we can hear from the witnesses, but it's properly before the committee. So unless there's a motion to table, the debate is now on the motion. The floor is open. Dr. Ellis.
Thank you, Mr. Chair, and certainly, this is perhaps, somewhat unexpected, but that being said, I think it's important that this committee understands the nature of the multitude of illnesses that exist with respect to COVID-19. Today, of course, we've heard some from witnesses and some experts with respect to long COVID and the devastating impacts that certainly creates for Canadians. We know from some of the papers that Dr. O'Brien has sent out that using multidisciplinary committees to begin to understand long COVID and the vast array of symptoms that can come along with it are very important. And I would certainly suggest that another illness coming along with COVID is that desperation, depression, and anxiety that exists with the inability to be reunited with loved ones, whether it be related to a funeral, as my colleague mentioned, or whether it be simply related to the inability to go and visit those who are near and dear to us, when we realize that there are a multitude of Canadians out there who are, of course, choosing for their own bodily autonomy to not be immunized and are, of course, unable to access air, rail, and sea, although we do know from recent comments in the House that there are folks who are unimmunized who are able to access air, rail, and sea, which creates this distinct disadvantage for some within Canada, which of course is not that style of society that we are attempting to create here. I guess the other point that I think is very, very important for people to begin to understand is if there are folks out there who have significantly waning immunity after perhaps 6 months after their third dose, that we know that the likelihood of them being protected against infection is small, and that in fact, if there were those out there who were unimmunized who had a rapid antigen test or even a PCR test before travel, that they would indeed be safer to travel with someone such as myself, who has a multitude of COVID shots and certainly not required to have any type of testing before I access any type of public transportation. So this inequity, I believe, is certainly worth being addressed, and what better place to address it, sadly, than here in the Standing Committee on Health. And I think that this is an important issue which has been perhaps brought up in the House, but certainly not been able to sufficiently and adequately address it amongst members in a cohesive fashion, to really point out the inequities, as I said, of the Canadians who are unable to access public transportation, and indeed in a country the size of ours, with the expectation that they should drive around this country is really rather unfair. I think the other thing that's important, Mr. Chair, to give consideration to is that these individuals are also, if they are have such a desire, would also be unable to even leave this country. and that creates a significant issue for them if they were unimmunized, that they certainly couldn't access the United States and they couldn't access transportation. I suppose if they bought their own boat, maybe they could go somewhere else, but given that, this creates an inability not just to travel inside your own country, but to actually leave a country with whom you may disagree with many of the policies, especially this particular one on public health. So effectively trapping them inside their own country, which is really something that we've never seen or heard of before for folks who really are not incarcerated. And I guess the other thing to point out, Mr. Chair, would be to say that this would probably affect about 15% of Canadians, given that 80 some odd percent of folks would have had 2 doses of vaccine, and 15% of Canadians, I would suggest to the committee members, is not an insignificant number of people who have chosen not to be, in the current definition, fully immunized. So that being said, I think that this is a motion which some may see as inopportune. However, that being said, we do continue to study COVID-19 every other meeting in this committee. So, Mr. Chair, I thank you for your time and for your indulgence.
Thank you, Dr. Ellis. Mr. Davies, please.
Thank you. First off, I'm not sure that I disagree that this is an issue that the Health Committee should look at. I would point out for anybody who may be watching this that this is identical to a motion that was tabled in the House of Commons, and we had a full day of debate on whether or not we should remove travel restrictions and mandates. That doesn't mean that it can't come before the Health Committee, but we have had a full day with lots of points made on it. I also empathize very much with a part of the travel mandate aspect, and that is I would be happy to examine the science and data on whether or not requiring people to be vaccinated before they travel on federal transportation services is backed up or not by the data. I think that's a fair question. I certainly have seen data that suggests that the science may not support any rational connection between that anymore. One of the problems, of course, is when we say remove all travel mandates is that we're also including a mask mandate in that. And I think that's a very different matter. I personally think that masks, the science behind masks as being somewhat effective in helping to spread the drop of aerosolized droplet-based illnesses is very strong. And that's why I generally oppose any kind of attempt to say get rid of all mandates on federal transportation, because they fail to make that distinction between requiring to be vaccinated versus masks, or even, for instance, requiring foreign travelers to be vaccinated before they come to Canada, which has a different impact, which is that we don't want foreign travelers to get sick in Canada and then necessarily put a burden on our domestic healthcare system. Having said all that, I am a little disappointed that this motion was made with 50 minutes to go. I think it's disrespectful to the witnesses who are here. This committee had an entire discussion about how we would allocate our time, and we agreed that this meeting would be dedicated to long COVID and to COVID treatments, which are 2 very important issues. And I certainly think we can have this discussion on this motion, but I would suggest we do it on a different day when we can all be prepared for it. For the record, by the way, I don't think that the motion should have been in order, because I had no notice of this and had no opportunity to prepare for it. Although it's generally under COVID, we're talking about about mandates that are basically made in the transport ministry, not the health ministry. So it's a very tangential connection, very weak nexus between that issue and studying COVID, in my view. But I respect that the ruling's been made, and I'm going to move that we table so that we can hear from the witnesses here for at least the last bit of the meeting. So I move to table.
Okay, so a motion to table is tantamount to a motion to adjourn debate, which is not debatable, so we'll proceed directly to a vote. And I presume that we'll need to do it by a standing vote. I doubt that there's consensus on this point. So, Mr. Clerk, if you could take the vote.
Vote on the motion of Mr. Davies that debate on the motion now be adjourned. Mr. Hanley,
Yes, I support.
Mr. Johari,
I support.
Mr. Pulowski,
For.
Mr. Pulowski, could you repeat that, please?
I'm for.
Ms. Sidhu,
Support.
Mr. Vancouverden,
I support moving to adjourn.
Mr. Barrett,
Against.
Mr. Ellis,
Against.
Ms. Goodridge,
Against.
Mr. Fast,
Opposed.
Mr. Caron,
En faveur.
Mr. Davies,
En faveur.
Mr. Chair, yeas 7, nays 4.
Thank you very much, Mr. Clerk. Thank you very much for your patience, witnesses. We're going to continue now with rounds of questioning, and it is the turn of Ms. Sidhu, please, for 5 minutes. No, your time has been well used. Ms. Sidhu, please.
I believe that I still have time left as my time gets frozen once I move a motion.
Your time doesn't get frozen when you use a motion. You decided to use your time for the motion. Your time is up. In fact, it's well past. I recognize Ms. Sidhu.
Thank you, Mr. Chair. Dr. Art, you said biomarkers hard to assess. So what about the wastewater surveillance has become a useful tool for detecting variants to inform public health decision for COVID-19. Can you please expand on how this important tool is being used, and is the data available for the public?
I think Dr. Arts is trying to answer the question, but nobody can hear him. Go ahead.
Oh, yeah, well, you think I'd know after a few years of this, but what I was saying was all of the data on the wastewater surveillance, in particular the viral load assessments, is provided to our regional public health units, but also to Public Health Ontario and to the Public Health Agency of Canada. It's used in assessments for public health policies across Ontario. And similar systems have been set up in other provinces as well. In addition to that, we do assessments whenever there is a high level of SARS-CoV-2 in the wastewater at ports of entry, and then also in large urban areas where we're assessing this through Health Canada. There's 3 groups, University of Waterloo, University of Guelph, and Western University, that does that surveillance. And that is a more in-depth analysis of what types of variants are circulating in the population and the proportions of those variants. Now, that information is shared again to the Public Health Agency of Canada and the public health units and Public Health Ontario. That is also, there's an attempt to provide that information through the Ontario Science Table. It's a little bit more complicated in terms of its reporting, and we hope that that information will be shared. There is some confidentiality in relation to that information that is assessed, and that is more in relation to understanding when something is coming into the country and how it spreads. So that is up to the Public Health Agency of Canada to kind of assess and determine when they want to release that information.
Next question to Dr. Falcon. We all know long COVID-19 has a long impact on some chronic diseases. Do you think what kind of impacts you saw or you feel on chronic diseases such as diabetes or on mental health, especially on mental health, how it got worse, or how long COVID impacting on the population?
Well, for one, both of the chronic illnesses that you mentioned are risk factors for long COVID. And for those who get long COVID and who have these pre-existing chronic illnesses, we can see exacerbations. So for diabetes, you could see an exacerbation in the acute phase, and there could be issues with glucose management more long term. And with chronic illness, with mental illness, we certainly see a worsening of symptoms. This, of course, is multifactorial, but certainly the impact of just not being able to recover, the people find is very discouraging, and it's certain. And when you compound on that also issues with sleep, for example, all of that are ingredients for deterioration in pre-existing mental illness.
Thank you. COVID-19 has highlighted new and existing issues that make it a challenge to collect, assess, and share the use health data for the benefit of Canadians. I know that's a mandated letter in for the Minister of Health. He was tasked with working with the provinces and territories to create a world-class health data system for Canada. Would you have any recommendation in this development of a pan-Canadian health data strategy to improve Canada's healthcare data system?
Well, I think that certainly such an infrastructure could definitely be beneficial.
We can't hear you, Dr. Falcone. I don't know if...
Oh, do you hear me now?
What happened?
Hello? Can you hear me? Yes? All right. I don't hear any no's.
Dr. Falcone, I don't think it's on your end. I think it might be on ours.
Oh.
Can you try it now, Dr. Falcone?
Yep.
That's perfect. Okay. A brief answer, if you could, please.
Yes, excellent. So I think briefly one way that would ensure the success of such a mandate would be to have a committee that includes representatives from all the provinces and the territories and in different disciplines so that we could come together and come up with protocols and infrastructures that are consistent and coherent amongst across the country.
Thank you, Ms. Sidhu. Dr. Falcone. Next, we're going to go back to Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for all of the work you've done. I think it's really important, and I just do want to apologize to you guys. I know that you guys have worked very hard on this. I was moving a motion, as is the prerogative of this committee, and so sometimes that's what happens. But I specifically want to ask some questions to Dr. O'Brien. I think the way how you laid out the 6 lessons for COVID-19, it really made sense in my head. And so I was just wondering if you could simplify any further, or if you had any points that you think are truly important for policy makers in this country to bring forward as we go through as COVID goes on.
Thanks very much for the question. I think recognizing the role for rehabilitation first and foremost in the context of long COVID is important. And then secondly, ensuring access to rehabilitation services for those living with long COVID and ensuring that access is equitable. I think we're all on a learning curve. And speaking from my profession of physiotherapy, this is a time where we are growing and learning as the evidence emerges. So for example, rehabilitation is not just exercise and does not just have to do with physical activity. And we're learning that, depending on the pathophysiology of long COVID.
Dr. O'Brien.
Just to hold on one quick second, because we're not hearing you in the room, and I'm not sure.
Yeah, we're having the same technical problem we have with Dr. Falcone. So we're hearing you in the room, but only through the earpieces, not in the speakers in the room. So it's on our end, not yours. Just bear with us, please.
Just wanted to ask Ms. Goulding a quick question. Would you mind, if you're interested, send me an email address, because we are trying to engage some patient advocacy groups, and I'd really appreciate that.
Yes, absolutely. My pleasure.
Thank you.
Thanks, Eric.
Ms. Goulding, you should be aware that we are in public right now, so you can you may want to do that privately, unless you want everyone who's watching the webcast to get the answer to that question.
Ms. Goulding, I would highly recommend that you not share your email address. But I do
Ms.
think...
Goodrich, we're still having the technical difficulties. We're going to suspend for 3 minutes to see if we can get this resolved. Okay, I call the meeting back to order. Colleagues around the table, if you're having any trouble hearing the witnesses, if you plug in your earpiece, you will be able to get them through your earpiece. When we left off, Ms. Goodridge was just starting her turn. So, Ms. Goodridge, you have the floor.
Thank you, Mr. Chair, and thank you to the witnesses. And I think in that very brief informal conversation we had with Mr. Arts and Ms. Goulding, I think it goes to show how little information is in fact out there on the COVID long haulers, and some of that idea. And so I was just wondering, and I wanted to just let Ms. Goulding know, I think you've spoke extremely eloquently thus far, and you've apologized a few times for having an escape of words. From my perspective, you've done an exceptionally good job at explaining this, and I was just wondering if there's anything else that you want to leave us as a committee with to consider as we go forward in this, because we will be forming some recommendations at some point when this committee wraps up this study, and I think that your perspective as someone with lived experience is extremely valuable.
Thank you so much. I think what's really important to remember is that we're all Canadians. We all need support together. We need to support one another. Like we said in the beginning of the pandemic, no Canadian will be left behind. And I think we need to honor that and address the issue of people suffering with long COVID and really support their needs financially, with respects to getting access to care, and then definitely the trying to get to the bottom to figure out the underlying mechanisms of what's causing this disease to make these terrible symptoms that people are dealing with. People really are losing their lives. It's quite a serious issue, and what's terrifying is that it's so unknown to such a large percentage of the population that this could possibly be an outcome of having COVID. So people really need to protect themselves. So I think messaging is really important with public health, and just, messaging across to help people understand what we're going through, to deal with our situations with compassion, and really want to help one another get through this situation, because there are strength in numbers, and we are only going to go and get through this together. And fantastic things, outcomes can be made with new discoveries of chronic illnesses that people have been suffering for years on end from other communities, in light of the research that could find out, because there are many things that are overlapping with other illnesses in different communities. And so this research could be game-changing for millions of people. So just the importance of funding for clinical research and the support that needs to be met for long haulers to be able to live, be able to recover, and to be able to get back to be productive citizens of society. We all just want to get back to work. We want to enjoy the things in life that we used to enjoy. We want to have relationships with our families that live a meaningful life, and just recover, be believed, and supported. Thank you.
Thank you, Ms. Goulding. I believe that's my time.
Thank you, Ms. Goodridge. Dr. Pawlowski, please, for 5 minutes.
I'd like to ask all the doctors, either PhDs or medical doctors, Dr. Falcone, O'Brien, and Arts, you all mentioned the incidences being somewhere in the neighborhood of 10 to 30%. Now, I'm pretty sure you've all had the same experience as I, which is when it comes to COVID, the world's a little bit different because not only do we read the papers, but we also know a lot of people who've had COVID. I know we're not, I'm a doctor too. I know we're not supposed to listen to anecdotal evidence, but my anecdotal evidence and I, like Dr. Hanley, figure that the majority of people I know have had COVID. So all of my employees on Parliament Hill have had COVID. My family all had COVID. Most of the people I know have had COVID, and yet, to my knowledge, none of them complains of long-term symptoms. So 10 to 30%, doesn't that seem a little bit high to you? And isn't part of the problem that with rapid testing having supplanted PCRs, we really don't know what percentage of people have had COVID. So again, the question is, do you really think it's as high as 10 to 30%?
I'll take the first stab at that if nobody minds. I think we can't, you're right, we can't estimate the actual percentage. Right now, all we have to go by is wastewater surveillance to kind of estimate the rates in the population at this point. And, I would suspect from modeling data that it probably is close to 30% of the population that's been infected now. The percentage I don't think is the important point. It is the severity of the cases that we see and the number in the end, because we can all agree that if 10 million people were infected, then the impact on society will be quite devastating. And I don't like to be a doomsday sayer. I'm always on the side of someone who says, I think it's not as bad as we all think it is. But in particular, I look at severe cardiovascular events and also these cognitive impairments. That to me is the gravest concern. And we struggle already in our healthcare system in dealing with dementia and Alzheimer's and Parkinson's. And I think that's where the difficulties lie. And the last point I'll make is I had it. I mean, I'm not one as well to acknowledge symptoms, but I was out for at least a month and a half, and that was with Delta, and that was prior to my ability to get vaccinated, just because it was too early for me. It took me quite a long time to recover, and I still have some minor effects. Now, is it debilitating? No, not for me. I had to do a pretty busy work schedule. But if it is mild, in my case, I can see how it could be more severe in others. And so that's anecdotal. But
okay.
Yeah.
Okay. Thanks. I wanted to get one more question in that was whether either the vaccine or treatments reduce the incidence. Now, I think either Dr. Falcone or Dr. Arts have said no, that there isn't a correlation, meaning that people who have more severe COVID are more likely to have long COVID. However, I think Dr. Falcone, I'm not sure which of you mentioned a recent study from Harvard and University of Pennsylvania finding people on ventilators, 40% had a cognitive decline. Again, anecdotally, if nothing else, certainly amongst the general population, you're not getting anywhere near as much as 40%. Is there not some inclination that there is a correlation? Certainly the English found it, but now in more recent studies isn't part of the problem. We don't know the denominator in mild COVID as to what percentage of the population have had it, whereas we do know the denominator with severe COVID because we know who's been in the hospital, who's been in the ICU.
A brief response, if possible. Dr. Pawlowski used up all of his time in posing the question.
maybe let me ask Dr. Falcone, since I concentrate on Dr.
Succinctly, please.
I agree. The fact that we don't know the denominator makes it very hard to estimate the prevalence. But even if it's a couple of percent, with such a large denominator, potentially, it's a huge amount of individuals.
Thank you very much, Dr. Falcone. Monsieur Garon pour 2 minutes.
Mr. Garon, 2.5 minutes. Thank you, Mr. Chair. I'd like to try to ask a shorter question. We talked a lot about research results. It's very interesting, but I'd like to talk about the funding for the research. I'd like to ask Dr. Falcone the following question. Has the COVID crisis changed the way we perceive clinical research? Do we need to change the way we fund clinical research in order to be better placed in the future to face public health crises? Yes, I do think we had a good response with research in the context of the pandemic. However, we did learn that COVID has a lot of surprises up its sleeve. There are new hypotheses coming out. They don't all have the same preliminary data that they're based off of. There are some projects that could be a little bit more risky, but they might be more profitable, especially when we have to mobilize rapidly. To be more specific, then, you talk about special funds for situations that are very serious or where we have to act quickly. So a system where we could unblock the funds quickly, and this could be done in parallel to standard funding. Indeed, that is a system that we could have. Last question. I think I have a minute left. We talked about the denominator and its prevalence. Should we be worried long term about the effects of long COVID on the workforce, also on hospitals and the pressure it puts on them, which are underfunded? Are these concerns that you share? Yes, because especially with regards to long COVID, well, it can vary in length. It could be months, years. We have seen people who are in clinics 2 years after their acute symptoms, and they are unable to go back to work. Thank you. I think my time is up.
I'm going to come from Mr. Davies, please, for 2.5 minutes.
Thank you. I'm not sure who the right person to ask this to is, so whoever feels that they can answer. Is long COVID impacted by the particular variant? Like, have we seen is it linked at all to, let's say, the Omicron versus the Delta or any previous version?
It's going to be very difficult to assess in past clinical studies because too many people did not have that information in terms of what strain they were infected with. However, we do know based on time periods the likelihood of you being infected with one type of variant or versus the other, so that those assessments can be made. So yes, there is large cohort studies that could be used to assess that information, although it creates a bit of an epidemiological study nightmare. But I think some things will work out in regards to understanding that better. One thing we do know is Omicron, for example, and Delta were pretty distinct variants in terms of their population size and also when they occurred. So that we have pretty understandable data for. But those...
Copy there. I think I got the answer. I just want to give the last word to Ms. Golding. I do think it's so important that we hear from patients, particularly when you're dealing with a new phenomenon. So last word to you, Ms. Golding. What would you like the federal government to know first and foremost, and what thoughts would you like to leave us with as a representative of many people suffering from long COVID across the country?
think it's important to recognize that the pandemic isn't over. It's not nearly over with all the new waves and variants. Long COVID continues. More people are joining our groups. When is this going to end? So I think that it's just really urgent to understand the fast nature of how we need to get on top of this while we can. It's just compiling, and the numbers are growing, and so this is really an urgent situation that needs to be brought to the top of the criteria. People are really suffering here. We don't want to see this happening to more people. We need to understand what is happening. We need to help our researchers, again, in funding their efforts, perhaps in different ways that we're used to. You know, it's very frustrating for researchers to get their studies up and running when there's setbacks from, you know, their getting their budgets or whatever needs to get going. And so everything is just taking such a long time to get rolling. We just really need to get on top of this. Canada really lagged in recognizing this. The first recognition of long COVID was in July of 2021 with Dr. Tam's announcement that there was such an outcome. And I think we really need to step up to this illness and like other countries have made significant contributions to dealing with the necessary issues and of supporting with funds, billions of dollars in the States allotted to research and funding for long COVID, as well as recognizing it as a disability, and which would give people access. And so I think critical things so that people are really suffering because they can't go back to work. They don't have access to food, to the basic necessities of life. And I think that that's something that you need to rectify right away.
Thank you for sharing that.
Thank you, Ms. Goulding.
Thank you.
Colleagues, just stand by. I'm going to thank the witnesses, and then we've got a little bit of committee business we need to deal with before we wrap. So to our witnesses, today you got the full experience. You got a late start because of votes. We had technical difficulties. We had a debate on a motion in the middle of the meeting. Thank you for hanging in there. Thank you for staying with us. Ms. Goulding, we wish you good health, and thank you for your advocacy. Dr. O'Brien, Dr. Arts, and Dr. Falcone, thank you so much for the patient and professional way that you've handled all of the events today, and thank you so much for the work that you do in taking on this global pandemic and ensuring that that we're able to move forward with the expertise that you contribute to it all. And so thank you so much for being with us. Colleagues, you have received a budget for the Children's Health Study. It's an estimate of $22,000. That budget is not at all cast in stone, but it's something that we do need to approve, and it takes into account the possibility that we will actually have witnesses come here to testify before us, as well as the cost of sending headsets and the like. So I would be pleased to entertain a motion to adopt the budget on the Children's Health Study. Thank you, Mr. Davies. Is there any debate? All those in favor of adopting the budget as presented, please indicate. The motion is adopted by consensus, and is it the will of the committee to adjourn the meeting? Yes. I see consensus. We're adjourned. Thanks, everyone.